Now one thought I had was when we were doing this liver was how do we interpret this liver function test, which I thought was very important because most of us ask for LFTs and we have no idea how to interpret them. So that is the reason why I included this particular slide of interpretation of liver function test. Just before we go on to interpretation, we need to understand the anatomy of the liver. The liver is divided into two lobes, right and left. Each lobe is divided into various semi-lobes. So there are four lobes classically, the caudate lobe, the quadrate lobe, the left and the right lobe. And the right and the left lobe is divided by the ligamentum teres. Now each lobe is divided into sub-lobes. There are 8 segments that are there, 1, 2, 3, 4 on the left side and 5, 6, 7, 8 on the right side. Each segment has its own arterial supply, own outflow, that is the biliary tract and biliary drainage. Why it is important to know these segments is because from the point of view of liver transplant, when we are doing a live related donor transplant, for the adults the right lobe is usually taken, for the vachus the left lobe is usually taken. So even if the adult undergoes, even if the donor gives a part of the liver, because it has its own supply, it's not going to affect the remaining part of the liver and they do well. Plus whoever gets the liver is also not affected. Now the porta hepatis is the most important area of the liver, where the portal vein, hepatic artery and the common hepatic duct form the triple structures. So you have portal vein supplying blood to the liver, hepatic artery supplying blood to the liver, and you have the common hepatic duct which drains the bile from the liver. Now this is the most important part of the liver. This is the porta hepatis. Your congenital hepatic fibrosis starts here, and this is also a cause of your pre-sinusoidal portal hypertension. So as I told you, for liver transplant the lobes are very important to know and the segments are very important to know. Then if we cut the liver and look at the microscope, we find a hepatic lobule. The central vein is at the center, and the portal tract, the triad of the portal, that is this hepatic artery, portal vein and the common bile duct, they are at the angles of the lobule. This is the picture of the lobule, which you can see the center is the vein. On the side you can see the red color is the hepatic artery, the blue color is the portal vein. Both are going into the central vein. On the sides the brown color is the hepatocytes and the green color is the bile duct. So this is your hepatic lobule, and there are zones. Zone 1 is near the portal tract and zone 3 is near the central vein. So anything which affects the central vein like a Budd Chiari, you are going to get problems near zone 3. Anything that is in neonatal cholestasis, you usually get problems near zone 1. Your autoimmune hepatitis in liver is interface hepatitis in zone 1. Zone 1 is also the area, zone 3 is also the area where oxygenation is poor. And zone 1 usually in cases of hemosiderosis is affected. Zone 3 it's usually in paracetamol poisoning, and zone 2 in cases of yellow fever. And that's why your liver functions differ in all these conditions. And how do we interpret the liver function test? What does the liver do? Basically it synthesizes protein, albumin, prothrombin, all your anticoagulation factors. Bilirubin metabolism, it helps in excretion of a lot of waste material through the bile, carbohydrate metabolism and fat metabolism. So traditional liver function tests that we've done are, we have the bilirubin, albumin, prothrombin time, SGOT, SGPT, alkaline phosphatase and GGTP. Whenever we ask for liver function test, two things that are never done are GGTP and prothrombin time. These two things should be asked in any patient with a liver dysfunction. So don't forget to ask GGTP and prothrombin time in these patients. For a synthetics, for looking at the synthesis of the liver, we look at proteins, albumin and PTINR. If we are looking at the excretory function, obstructive versus non-obstructive, we look at bilirubin. If we are looking at any problem in the biliary epithelium, obstructive jaundice, we look at alkaline phosphatase and GGTP. And if we are looking at injury, necrosis to the hepatocytes, SGOT, SGPT. So that's how we look at the various liver function tests. If we have an increased bilirubin, it tells us there is a hepatocyte injury or there is cholestasis. If there is increased SGOT, SGPT, hepatocyte damage. Albumin is low. Albumin has a long half-life, 3 weeks. So it suggests more of chronic liver disease. But let's talk about SGOT, SGPT. Why do we need to do both the things? Why SGOT? Why SGPT? Both of it. We could only do SGPT. Why do we need to do SGOT? Because these ratios help us. If usually SGPT should be more as compared to SGOT in any liver disease. If SGOT is more as compared to SGPT, and if the ratio is more than 2, in adults it will suggest alcoholic liver disease. If the ratio is less than 2 but more than 1, you think of Wilson's. And if the ratio is otherwise, it's less than 1, that means SGPT is more, it suggests more of viral hepatitis, non-alcoholic hepatosteatosis, NASH. If the SGOT, SGPT is more than 20 times, definitely it's viral hepatitis or drugs. If it is 3 to 20 times, it's usually chronic hepatitis or autoimmune hepatitis. And slight elevation of SGOT, SGPT, think of NASH. That's how you interpret the liver function test or the liver enzymes. Prothrombin time, as I told you, is again one of the reasons of liver dysfunction, synthetic function of the liver. Prothrombin time prolongs in a matter of hours. So if I have a prothrombin time, it tells me acute liver cell failure. Albumin tells me chronic liver disease. So if I have a child with viral hepatitis, I would do a prothrombin time and see whether he's going into fulminant hepatic failure. So that's the importance of doing prothrombin time in every patient who has a liver dysfunction. GGTP is only, it's very sensitive, so it's not very useful, but you need to do in any patient who has a high alkaline phosphatase. With high alkaline phosphatase, if GGTP is high, it tells you there is an obstructive liver disease. In adults, when SGOT is SGPT is more than 2 ratio and GGTP is high, it tells you alcoholic liver disease. In neonates, neonatal cholestasis, if GGTP is normal, it tells you PFIC. So this is the way GGTP is going to be useful in these patients. And only increase in bilirubin without elevated SGOT, SGPT. If it's unconjugated hyperbiliry, think of Gilbert's or Crigler-Najjar. If it's direct jaundice, think of Rotor's syndrome or Dubin-Johnson syndrome. These are benign conditions, so you don't really need to worry about these conditions. I found this very good algorithm in Pediatric Gastroenterology Journal 2013, which says that if you have a child with elevated liver enzymes, you do a total bilirubin. If the bilirubin is normal, but just SGOT, SGPT is elevated, rule out infective hepatitis B and C. If that is also normal, do a ceruloplasmin to rule out Wilson's. If that is normal, then you must rule out non-alcoholic fatty liver disease or other viruses such as CMV, EBV, parvovirus and all that. If your bilirubin is elevated with elevated enzymes, rule out hepatitis A. If that is ruled out, rule out autoimmune, drug-induced or probably congestive cardiac failure or biliary atresia. So this algorithm I found very useful. Look at enzymes, look at bilirubin and then work up the child. So this would be probably something that we could use in these patients. Can anyone tell me what this is? This is a child who's got a lot of bleeds. He's vitamin K deficient. He's just got ecchymosis all over the skin. This is vitamin K deficiency because of liver disease. Chronic liver disease, we usually earlier used to state that any patient who has elevated liver enzymes for more than 6 months we label as chronic liver disease. No longer true. Anyone who has a liver disease that is capable of going to cirrhosis, liver failure or death is considered as chronic liver disease. So you may get a Wilson's who may suddenly come to you with just acute hepatitis, but there is an underlying liver damage that is going on, then you label them as chronic liver disease. Most of these patients will present as jaundice, variceal bleeding, hepatosplenomegaly, elevated liver enzymes and low albumin. Low albumin is very important. They may come to us as acute jaundice, they may come to us as gradual signs of liver disease, or they may just come to us as hepatomegaly. Common causes of chronic liver disease, infections B and C, metabolic, Wilson's, autoimmune, NASH. Don't forget tyrosinemia, galactosemia. Alpha-1 antitrypsin is rare in our country, so don't even bother working up children for alpha-1 antitrypsin deficiency. But chiari can lead beyond chronic liver disease. And then obviously neonatal causes like biliary atresia, PFIC and allergy. Age distribution wise, storage and neonatal cholestasis more common in less than 5 years. Viral hepatitis, autoimmune and Wilson's disease more common in older children. How do we treat this chronic liver disease? One is dietary modification, especially in cases with galactosemia, hereditary fructose intolerance, GSTs, NASH, Wilson's disease, and tyrosinemia. All of them require dietary modification. If it's B and C, then obviously interferon, ribavirin, lamivudine would be required. And there are other drugs that are now come up. In fact, in B and C, there's so many drugs that have recently come up that it's a very exciting field now to treat, especially hepatitis C, which can almost be eradicated if you treat them on time. Adifovir has been used in children, entecavir not recommended right now in children, but as the first line in adults. Then you have emtricitabine, tenofovir, which are actually ART, HIV drugs, which have been found useful in hepatitis B. Sofosbuvir has now come into India for hepatitis C. It's being used in adults, not yet used in children, but suddenly now it's found a lot of weightage. And hepatitis C treatment depends on even the genotype that is there. And you now have combination therapy with interferon, ribavirin and sofosbuvir, depending on the genotype which ones to use. Autoimmune hepatitis, corticosteroids with or without azathioprine and cyclosporin. Monitoring of chronic liver disease, nutritional management is important. Look for ascites, spontaneous bacterial peritonitis, portal hypertension, hepatic encephalopathy, and timely referral for liver transplant. Now this particular slide, can you tell me what this patient has? This child came to us with abdominal pain. Somebody did an ultrasound, found a cyst in the liver, a CT was done, and this was the kind of cyst. So what is this? This is a hydatid cyst. And hydatid cyst, how do we prove it? We are not going to put in a needle to see the hydatid cyst. You could do an Echinococcus ELISA. If that is positive, it is hydatid cyst, and the treatment is just albendazole. You don't need to do surgical intervention for every patient with hydatid cyst. If the cyst spills over into the peritoneum, all those cholexes will go into the peritoneum and seed it. So you could get away with just non-invasive treatment and non-invasive method of testing these patients. Now we'll go through few cases. 8-month-old boy, sudden onset ascites, no jaundice or fever, and you get a hepatomegaly. He's just come to us as sudden onset ascites. LFT wise, except for HBV which is slightly elevated, everything else is okay. He's not that bad. So what would you do in a child who's had sudden onset ascites? This is not neonatal cholestasis. There is no rise in the bilirubin. What would you do? Shall we tap him and look at the SAG ratio, or look for tuberculosis, or look for peritonitis? Okay, in this child, what we did was we did an ultrasound with a Doppler, and it showed a thrombus in the middle hepatic vein with a patent right and left hepatic vein. So this was Budd-Chiari. So Budd-Chiari in infants can come to us as just sudden onset ascites. Because of the back pressure, the first thing that will develop is ascites. Now the next step, what should we do? Further steps. He's got a thrombus sitting there, sudden onset without any precipitating factor. Obviously we are going to do a thrombotic workup here. He had a protein S deficiency. Treatment of Budd-Chiari, we put them on anticoagulation, and we have to do a angioplasty. Now here, when we did our Doppler, we found that the middle hepatic vein was not patent and the right and left were patent. When we did an angiography, we found that there was stenosis of this right hepatic vein and the left hepatic vein, and the middle could not even be cannulated. So what was done is a right hepatic venoplasty and a left hepatic venoplasty, and anticoagulation in the form of warfarin or heparin was started in this child. So sudden onset ascites, don't forget Budd-Chiari. That's the carry-on message. Don't ever forget Budd-Chiari and look at the Doppler. Can you tell me this child? Large liver, protuberant. Look at his face. This is glycogen storage disease, GSD, type 1. They have very infantile faces, baby faces, short stature, really huge abdomen and a large liver. When you see such a large liver, think of glycogen storage disorder. Doll-like faces. Now this is another case. This is a 5-year-old girl. She has abdominal distension and failure to thrive for a year. She has been treated with anti-TB treatment at 3.5 years for 6 months. When you see her, you find she has alopecia. She has pallor and she has splenohepatomegaly. So obviously this is some sort of a chronic liver disease. Liver biopsy shows interface hepatitis. An ultrasound shows splenohepatomegaly with portal hypertension. Anybody can think what is the cause of her chronic liver disease? She's 5 years and she has alopecia. Yeah, so we think of autoimmune here. And here when we did our liver function test, HGOT, HBV slightly elevated, albumin lower side 3, HBsAg, HCV negative, ANA negative, anti-smooth muscle negative, anti-LKM positive. So she was autoimmune liver disease, 24 hours urine copper was normal, Wilson's was ruled out. So hepatitis B, C was ruled out, Wilson's was ruled out, and this was autoimmune liver disease treatment, which on biopsy will classically show interface hepatitis on liver biopsy. So treatment here would be steroids and probably azathioprine in this child. This is another patient. Can you tell me what this patient has? Look at his eyes. Yeah, there are cataracts in this child. So if I have a child with cataract, what is the first thing that I'll rule out? Galactosemia. Excellent. And this child had galactosemia type 2. He didn't have a liver disease, but he had a galactokinase deficiency. Wilson's, I thought I'll just touch it up a little brief because we see so much of Wilson's. Wilson's can come in two forms, hepatic or neurological. Hepatic can come as acute liver cell failure or chronic hepatitis. They tend to have Coombs negative hemolytic anemia. And neurological can be in the form of 4 types. They can come to us as Parkinson's, they can come to us as ataxia, dystonia and tremors. So these are the 4 variants of neurological that they can come. We diagnose Wilson's not on the basis of one test but a gamut of tests because there is no 100% foolproof test that will tell us this is Wilson. So we do serum ceruloplasmin, low, 24 hours urine copper, elevated more than 100, KF ring, Coombs negative hemolytic anemia, and we do a copper content in the liver biopsy more than 250 micrograms per gram of liver. The 100% gold standard is doing a genetic test, that is a mutation analysis. Now among your Wilson's, nothing is foolproof. So you could have a child with Wilson's without a KF ring or a KF ring present and 24 hours urine copper not elevated. So there is a scoring system that has been developed in 2001 which gives a scoring system as to how do we diagnose Wilson's. 4 things that you first look at: KF ring, neurological symptoms, serum ceruloplasmin and Coombs negative hemolytic anemia. If you have these conditions, you don't even need to do liver copper, you don't need to do 24 hours urine copper or mutation. But if you don't fit into that scoring of 4 or more, then you do the remaining test of liver copper, 24 hours urine copper or mutation analysis. So I think this scoring system is pretty useful to make a diagnosis of Wilson's. King's College London developed a prognostic index. When should these patients with Wilson's disease undergo liver transplant? And it was found that if you had these, you look at the bilirubin, HGOT, HEPT, INR, WBC and albumin, and if you have a score more than 11, they will probably die without a liver transplantation. So you need to do liver transplant with this scoring system. Treatment wise, we give them chelators, penicillamine or trientine, zinc and vitamin E. Trientine is basically preferred for neurological Wilson's because penicillamine may deteriorate their neurological condition. Zinc is basically given to prevent absorption of copper from the GI system, and vitamin E works as an antioxidant. Usually you don't give zinc and penicillamine together. Very rarely you'll give a combination therapy. If you're using penicillamine, it has to be given before meals or at least 2 hours after a meal because meal interacts with penicillamine. With penicillamine, always give pyridoxine. If we are using zinc, zinc should be given before a meal so that it starts working when the meal is taken. So usually don't use a combination. The moment you need to monitor these patients for copper excretion in the KF ring. On treatment, KF ring should disappear. On treatment, the urinary copper should go down. So penicillamine is pretty toxic drug. There are side effects. You need to monitor urine routine for albuminuria, the creatinine and all these various things. From the year 2007 to 2009, we had, in the span of 2 years, we had 12 children with Wilson's. Mean age of presentation was 8.8 years. Most common symptom was splenomegaly, jaundice, hepatomegaly, ascites, RTA. Neurological was rare. KF ring was present in almost half of them, and hemolytic anemia. Most of them came to us in acute liver cell failure, 33%, of which almost 83% had portal hypertension, and chronic liver disease in 11. All those who came in acute liver cell failure died. 3 patients we lost to follow-up, and the remaining are continuing on treatment, but they have signs of chronic liver disease on follow-up. This is a child who came to us with jaundice and hypertension and renal failure. This is the CT scan. Can someone tell me what it is? This is Caroli's disease. Caroli's disease with polycystic kidney disease, and you can see all these dilatations of the biliary tract in the liver. So this is Caroli's disease. Another case, this is a 17-year-old boy who came to my clinic in September 2014. He had elevated liver enzymes in Jan 2014. So almost for 9 months he had these elevated liver enzymes. He had jaundice in Jan to begin with, but the jaundice had disappeared. He had no blood transfusion. On examination, no hepatomegaly, no splenomegaly. His weight was okay, 66. So this is a serial LFTs. You can see the bilirubin came down. HGPT in Jan was in 2000s, came down to 400, 112, 64, 54, 69. So it tended to remain around this level. So he was a chronic liver disease. We did an ultrasound. It showed increased parenchymal reflectivity of liver. Otherwise it was normal. BC was negative, autoimmune negative, Wilson's workup came negative. So in this child we didn't have a cause of his liver disease. In November his HBP went up to 113. So this was the time I did his liver biopsy, and it showed macro and micro steatosis and very minimal inflammation. Lipid profile was normal. So this child was diagnosed as NASH, non-alcoholic steatohepatitis. What is this NASH? It's what we have is a spectrum. It is known as non-alcoholic fatty liver disease, where there is no inflammation of the liver and only fat deposited in the liver, to a spectrum known as NASH, which is non-alcoholic steatohepatitis, where there is inflammation also along with fat. So this is a spectrum that shows that from fat to inflammation, scarring, and then finally cirrhosis. This is a very upcoming entity in children, mostly related to obesity. So this is the slide which shows only fat, no inflammation, and NASH is with inflammation. Common causes are drugs. HIV patients are going to get these conditions because of antiretroviral therapy. Methotrexate, TPN. Obesity is one of the commonest causes. Diabetes mellitus, hyperlipidemias, and in adults it's alcohol. Other causes of fatty liver, you could get it with Wilson's, mitochondrial hepatitis C, and even with cystic fibrosis. NASH, it's basically 2 mechanisms of action. One is insulin resistance, and second, injury occurs because of oxidants, genetic causes, or environmental causes. They usually present with asymptomatic elevation of liver enzymes and hepatomegaly. Some of them may have obesity, diabetes, or acanthosis nigricans. Diagnosis is based on liver biopsy. And treatment-wise, if obese, they need to lose weight with diet and exercise. If there is hyperlipidemia, we need to give anti-hyperlipidemics. We could give vitamin E as an antioxidant, and we could give urodeoxycholic acid, which can improve liver functions in these patients. So don't forget NASH. This is an upcoming entity of chronic liver disease in children. This photograph, there is a huge abdomen. The abdomen is more swollen in the upper quadrant. There's a lower quadrant is not as prominent as the upper quadrant, and there are these blue markings over the skin. Can we think of anything? So this child has a organomegaly because it's in the upper quadrant, so probably it's a hepatosplenomegaly, and these are blueberry muffins. Organomegaly with blueberry muffins, first thing is congenital syphilis. Second is GM1 and GM2 gangliosidosis. This child had GM1 gangliosidosis. So when you see this kind of a rash with hepatosplenomegaly, don't forget storage and syphilis. There are other metabolic liver diseases which I could go on and on: glycogen storage disease, tyrosinemia, galactosemia, hemochromatosis, alpha-1 antitrypsin. But I don't think we have time to talk about so many disorders. So I'm going to end the liver talk by saying that liver diseases in children, spectrum of problems. I told you about neonatal cholestasis being the commonest. Portal hypertension, how do we manage them? Wilson's disease, what to do, autoimmune, a few cases that we discuss, and an upcoming entity of NASH. They range from metabolic, autoimmune and infective causes, and judicious assessment and decision regarding further management has to be taken. And I must acknowledge the Pediatric Oncall team, which has helped in setting up this web conference, otherwise this was not possible. And this is the Pediatric Oncall app, which you can download on your phone, which I've been using and I find it very useful in day-to-day practice. And thank you very much.